Okay, so our topic is neurodiversity affirming practices. An introduction to our group. Hi, my name is Abby Johnston. I will be the moderator for our group. I am from Crown Point, Indiana. I am currently a registered behavioral technician. I've worked in the field for about 2 years now. I work in a clinic-based setting. I also do some home-based work with one of our clients, and I am excited for this debate.
Hey, I'm Elizabeth Smith. I will be debating the con on the medical model. I live in Vidalia, Louisiana, and I'm currently teaching special education 9th through 12th grade self-contained class. Not too exciting here.
Hi, my name is Adriana McAllister. I'm from Monroe, Michigan. I will be arguing the pro side, specifically the social model of disability. And I have worked in the field of ABA for 8+ years, primarily ages 3 to 5, but more recently ages 3 to 18.
Hi, I am Kennedy Campbell. I am from Lindstrom, Minnesota. I am arguing the con side, specifically in terms of ableism. I've been in the field for about 2 years. I work mostly in a clinical setting and do early intervention, so like ages 3 to 12.
I am Jenna Van Dyke. I am from Palm Harbor, Florida. I am arguing the pro side specifically for reducing ableism. I have been working in this field for a little over 5 years now, working primarily doing early intervention, but in the last few months adding in some school clients as well.
Okay, so what is neurodiversity? Neurodiversity is the concept that neurological differences such as autism or ADHD are a normal variation of the human brain, promoting the idea that these differences should be recognized and accepted in society. Neurodiversity affirming practices refer to strategies aimed to support individuals with diverse neurological differences across different settings. A common example is an individualized support plan in which interventions and support are based on the client's needs, preferences, and strengths. The purpose of these practices is to create an inclusive environment that recognizes each individual's way of thinking. During this debate, we'll be analyzing neurodiversity affirming practices, such as the use of the social model of disability and contrasting it to the medical model. The medical model is a framework used to understand health and illness, primarily through biological factors. It focuses on diagnosing and treating physical ailments based on psychological processes. In contrast, the social model of disability is a framework that defines disability not as a result of an individual's impairment, but as a consequence of societal barriers. During the debate, we will also analyze ableism, which can be defined as beliefs or attitudes that people with disabilities are less capable than individuals without disabilities. During the debate, we will have our pro side, which will include Adriana and Jenna, who will be arguing to reduce ableism and support the social model. We will also have our con side, which includes Kennedy and Elizabeth, who will be arguing against neurodiversity affirming practices. So during the debate, I will pose a question, and each side will have an opportunity to respond and rebuttal their side. So with that being said, our first question is, should behavior analysts prioritize awareness of ableism and its effects on service delivery? I will first open up the discussion to our pro side with Jenna.
Thank you. Our side is arguing that yes, behavior analysts should prioritize awareness of ableism and its effects on service delivery. Adriana will be going more in depth into the social model of disability later on in this debate, but essentially it claims that society's lack of understanding and acceptance is what creates a struggle for those with autism and other disabilities rather than any of their perceived deficits. There should be a focus on adapting the environment and supporting the individual's strengths rather than trying to increase compliance and making the individual act more normal, as this is a way to help reduce the harmful effects on the individual's autonomy and free will. The movement provides several suggestions on how to do this, which can include increasing acceptance of neurodivergence in societal norms, as it can decrease the negative effects of things such as masking or self-stimulation, which we also call stimming. Another way is to incorporate an individual's strengths, preferences, and internal experiences into interventions instead of developing them with the intention of solely reducing the inherently autistic traits in favor of more normal, societally acceptable ones. And if you look off to the right, we have this graphic that shows the main pillars of neurodivergent affirming care. The first one is sensory soothing, which is helping people self-regulate and understand how different sensory input influences the individual's emotions and their ability to regulate. The next one is addressing ableism, which is encouraging practitioners to first address their own ableism and then assist clients as they identify and work through their own internalized ableism. The third pillar is self-advocacy and executive functioning support, which is essentially supporting self-advocacy and supporting clients as they develop their own systems to support their basic needs. The fourth is incorporating interests by utilizing the client's interests and passions in therapy in order to access their inner world and enhance psychoeducation for a deeper learning and engagement. And the final pillar we have is affirm identities. This can be done by helping clients recognize and affirm their own identities and helping them understand how all of those different identities intersect to impact their social context and life experiences.
Thank you, Jenna. Now I would like to open up the discussion to our con side with Kennedy.
Hi, I will be arguing the con side for ableism. In 2013, the diagnosis of Asperger's syndrome was absorbed into the larger category of ASD, which was assigned levels ranging from 1 to 3. The levels were dependent on the amount of support that each individual required. This change in diagnoses lumps low support individuals who might not need much support into levels with those who are considered high support individuals and are so severely disabled that it greatly impacts their ability to participate in activities of daily life. The movement encouraging autistic voices to be part of the solution is in good faith, but it does alienate those who require more support and may not have a traditional way to communicate their thoughts and feelings. This leads to a more ableist and whitewashed dialogue within the movement. Many high support individuals are considered too significantly disabled to be included in the neurodiversity movement, so the paradigm can only really be applied to low need individuals. As the high and low support are technically in the same category of autism, the low support individuals are more likely to be underrepresented, as they are less likely to have a voice. How can these individuals claim to speak for all autistic voices if they are not able to comprehend or understand the experiences of others? The movement claims that ASD is a natural variation in human functioning. This is concerning as it is a narrow conception of neurodiversity, which refers almost exclusively to low support autistic individuals. This movement is also heavily white in terms of how it is packaged, described, and perceived. This leads to people of color who display the same neurodivergent characteristics as someone who is white to be met with negative consequences, while those who are white are met with a more forgiving tone. Instead of what is currently occurring, the movement should be a radical and inclusive space that allows for the whole spectrum of individuals to be represented. Finally, neurodiversity affirming practices are particularly difficult to put into practice for a number of reasons. One such reason is that the neurodiversity movement states that intervention should be reflective of the individual's perspective, internal experiences, and preferences. This is difficult to meet when the individual is not able to articulate or communicate what these may be for themselves. Quality of life should also be a priority to providers according to the BACB Ethics Code, but it can be hard to understand what that means for any given individual. Adversaries of the neurodiversity movement argue that there are certain aspects of ASD that can negatively impact an individual's quality of life, and providing interventions that reduce the behaviors impacting their ability to participate in daily life.
Thank you, Kennedy and Jenna, for your thoughts on this topic. I would now like to pose our second question for this debate. Which model, medical or social, provides a more effective framework for effectively meeting the needs of individuals with disabilities? We will first hear from our pro side with Adriana.
Hello. I would say that the social model does more effectively meet the needs of individuals with disabilities. The social model of disability is a framework that defines disability not because of an individual's impairment, but as consequences of societal attributes or attitudes and barriers. The social model really focuses on prioritizing functionality and socially valid goals, focusing on minimizing risk of harm psychologically and emotionally, harm brought to them due to trying to be normalized with the more of the medical model. It focuses on the strengths versus their weaknesses and tries to include stakeholders and clients in the creation and implementation of interventions. The two codes that apply to this are 215 and 209. 215 is minimizing risk of behavior change interventions. And 209 is involving clients and stakeholders. So this is what the social model strives to include them in the planning process, meeting their needs individually, including their strengths, and using those to build off of and have socially valid goals accomplished that will actually benefit the client in their life. The BACB code principle, treat others with compassion, dignity, and respect, is also applies to this because we focus on clients and stakeholders being included. We focus on the risk being minimized that's being posed to these clients. And in doing so, we make sure that we are meeting them with compassion, dignity, and respect. On the side here, we see visual called the diverse model of neurodivergent affirming practices. The first part is diversify perspectives, which is being aware of how the client and stakeholders see the world, supporting them in a way that will benefit them. While this is argued that is very hard to implement across the board and hard to transfer to other clients. While that's understandable, we have to put in that extra work to meet their needs individually so that we are giving them socially valid outcomes from their therapy that will profit them and not just society, making their behaviors seem more normalized. The second section is intersectionality, which is being aware that we all have differences we may be oppressed for, and awareness of this is necessary for effective and compassionate care. If we are not aware of our biases or biases that happen in the community, then we are not able to appropriately advocate for our clients. And that's what the social model advocates for. The next section says value neurodivergent voices. So this is, again, involving them in the planning, making sure that they're part of it, because at the end of the day, this is their therapy. This is for them, not to normalize them and make them seem like others in society. And the next part is embrace neurodivergent characteristics. This is, again, that not trying to normalize, making sure that we are not trying to make the client look like neurotypicals, but providing socially valid goals and treatments that will benefit the client and the families involved. Recognizing ableism, being aware that these biases and beliefs that individuals with disability, being aware of the biases that are out there that tell us that people with disabilities are less than neurotypicals, that they will not ever be as capable as a neurotypical person, and that is just not true, and we can accomplish that through the social model. And then we come to support, which is accommodate different learning styles, making sure that we're meeting the specific needs of each client and meeting it in a way that is beneficial for them. And then empathy towards difference. Again, understanding that they will have areas where they need to make improvement, and that's just a difference versus a deficit. Because we want to really focus on their strengths and build on those and increase their skills through the strengths. And really just showing that respect and compassion and dignity to our clients. So yes, I would say that the social model does provide much more effective treatment to our clients.
Thank you, Adriana. I would now like to open the discussion on the medical model with Elizabeth.
Thank you. I think the medical model is most effective because it presents a structured way to understand and address the disabilities by focusing on the diagnosis and treatment, which can lead to significant improvements in the health outcomes for individuals with disabilities. The medical model emphasizes the necessity of accurately diagnosing conditions and providing appropriate medical treatment. By doing so, it enhances health outcomes and improves the quality of life for individuals with disabilities. The proper diagnosis enables healthcare professionals to tailor treatments that align with the specific needs of individuals. And this follows along with the Ethics Code 201, providing effective treatment. The model empowers families by equipping them with the knowledge and strategies to support their loved ones properly, and it also plays a crucial role in facilitating across the vital healthcare resources and securing insurance coverage for necessary treatments, therapies, and other devices they may need. By ensuring access to these resources, the medical model supports not only the individual but also their families and helping them navigate through the complex of their disabilities. The medical model actively promotes research into the underlying causes and biological aspects of disabilities. Within the context of the medical model, behavior analysts play a vital role in providing effective treatment that prioritizes the client's needs and rights. They ethically mandated to deliver services rooted in the scientific evidence that align with the behavioral principles. So this approach ensures that all clients, stakeholders, trainees, and research participants are guarded from harm that may come from other things. And as a behavior analyst, we have a responsibility to implement the most effective and evidence-based treatments that serve the client's needs. And in cases where clients exhibit challenging behaviors, this will play a major role, and this refers to the Ethics Code 301, the responsibility to the client. And in line with the core principles of benefiting others, we as behavior analysts are expected to always place the client's rights and needs at the center of the treatment plans. And the aim of the medical model is fundamentally focused on curing and improving behaviors. And through the accurate diagnosis, effective treatment, and ethical practice, this model offers a comprehensive framework that can meaningfully enhance the lives of individuals with disabilities. And the picture or the visual is a good explanation of what the medical model is an example of, and the advocators that support and help throughout treatment and care for their client.
Thank you, Elizabeth and Adriana, for sharing your thoughts. We will now move into our closing statements for each side. We will start with our pro side with Adriana and Jenna.
Okay, so in conclusion, there are many reasons to support neurodiversity movement and the social model of disability. It reduces ableism in service delivery and programs such as it helps reduce ableism and that runs rampant through our society, causing a great struggle for individuals with autism, mentally, emotionally, and socially. The movement propagates that there should be focus on adapting the environment and supporting the individual's strengths rather than increasing compliance and making the client seem more normal, as this is a way to help reduce harmful effects on body autonomy and free will of the individual.
Suggestions provided include increasing acceptance of neurodivergence in societal norms, as it can help decrease the negative effects of things such as masking and stimming, as well as incorporating the individual's strengths, preferences, and internal experiences into interventions. This is supported through the Ethics Code for Behavior Analysts, codes 2.15, which is minimizing risk of behavior change interventions, and 2.09, which is involving clients and stakeholders.
Thank you. Now we will hear from our con side with Kennedy and Elizabeth.
While the neurodiversity movement brings many points that should be considered, there are also major flaws in aspects of their manifesto. While the movement proposes that all autistic voices are heard and valued, those who need less support and can communicate in a more socially acceptable way are those who proponent these claims. Those individuals who require less support and may have a non-traditional way of communicating are not represented in this movement. Therefore, the movement is inherently ableist, and the very structure of their party prevents an entire subpopulation of the autistic community from voicing their opinions.
The other major fault in the movement structure is that they provide no ethical and practical way for behavior analysts to put their changes into practice. As the movement is newly gaining traction, there is little research done on the effectiveness of the proposed changes. As more traditional methods are evidence-based, it is the behavior analyst's responsibility and ethical duty to base their interventions on such research. These claims are supported by the Ethics Code for Behavior Analysts, with codes 201 providing effective treatment and 301 responsibility to the client.
Thank you, everyone. I think this photo does a great job at examining the differences between each model. On the top portion, we can see how the medical model is depicted with the individual in the center with the problem arrows pointed towards them. This represents the traditional view of the medical model, which focuses on how a disability is impairing the individual. And while the bottom portion, we can see the individual is in the center and the barriers are on the outside, representing society as the barrier. This does a great job at showing how the social model emphasizes how the environment, organizations, or societal attitudes create barriers for the individual. In conclusion, we have heard from the pro side, which included Adriana and Jenna. And they have effectively argued for reducing ableism by advocating for the acceptance of neurodivergence and recognizing individual strengths during interventions. By emphasizing the social model of disability, they highlighted that disability is shaped largely by societal barriers and attitudes rather than solely by impairments. This perspective calls for systematic change and inclusivity, aiming to create environments that empower individuals and recognize their unique contributions. Ultimately, fostering acceptance and understanding of neurodiversity not only benefits those with disabilities, but enriches society as a whole. We have also heard from our con side with Elizabeth and Kennedy, who argued that the neurodivergent movement is not including the voices and opinions of lower functioning individuals who may not be able to communicate their wants or needs. They have also argued for the use of the medical model to better understand disabilities. They emphasize that this model allows for accurate diagnoses and the delivery of targeted medical treatments, which can be crucial for individuals seeking effective interventions. The medical model also focuses on the biological and physiological aspects of disability, providing a framework for understanding specific conditions and their implications for health. Okay, thank you everyone for participating in the debate. We will now move on to our questions portion. Our first question is, how do cultural factors influence the application of the social model of disability? The cultural factors can influence an individual's belief and views regarding a disability. In some cultures, disability is quite normal, while in other cultures, it can be viewed as a stigma. Societal and cultural norms play a factor in the acceptance and inclusivity towards individuals with disability. We will now hear from Jenna with the answers to our next two questions.
Thank you. Our next question is, how can practitioners best work with neurodivergent individuals to make sure their voices are heard in the decision-making process? One way for a practitioner to ensure that neurodivergent individuals are included in the decision-making process regarding their own treatment is to actively communicate with their clients and involve them in the decision-making process. The practitioner should be mindful of their own biases and encourage self-advocacy by providing clients with information and training to support their needs. Our next question is, what are some criticisms of the medical model? The medical model overlooks the social, cultural, and environmental factors that contribute to the experience of disability. It can lead to stigmatization and a narrow understanding of what it means to live with a disability.
Thank you, Jenna. Now we will hear from Adriana with the answers to our next two questions.
All right, our next question is, what are some criticisms of the social model of disability? The criticisms are that it downplays the biological and medical aspects of the disability and suggests that changing all of society's attitudes towards those disabilities is really where our focus needs to be. And it also adds too much complexities that makes it very difficult to transfer to other clients. These are some of the criticisms of the social model. And then our next question, is how does the social model impact implementation of services and treatment for individuals with autism? The social model makes the treatment look very different. The focus is on antecedent interventions, changing the environment, altering the plans to meet the client's strengths and needs, focusing on those strengths versus any compliance, they will not be trying to normalize, so they will not be response blocking, stemming that does not cause any issues, no physical harm or harm to others, using the present strengths that the client is showing when coming to treatment and using those to build other skills that they may not have at this time. Taking their preferences and their internal experiences into account when creating interventions, and making sure that we're not just focusing on reducing inherently autistic traits to appear more normal, and reducing the harmful effects that can be had when a client's autonomy and free will is not respected or considered. So these treatments, you're going to see these children are going to be have a lot less emotional outbursts because the plans are going to be individualized to that client. And you will see more focus on advocating for themselves rather than just complying with what is said. Having them speak up for themselves and ask for what they want, and not just saying, oh, no, you can't have that. Things of that nature. So that's how the treatment would look differently. Thank you very much.
Thank you. Now we will hear from Kennedy from our next two questions.
So question number 6 is, what are common interventions/treatments promoted by the medical model for individuals with autism? So the medical model focuses on trying to increase normalization and compliance as outcomes. It was developed initially with the intention of curing or making autistic individuals more normal. An example of this would be a play program. Currently, most programs are written with the intention to get the child to play correctly or as a neurotypical child would. If the autistic child doesn't play with the toy or the game in a correct manner, they are prompted to play with it not as they would with their imagination or how they normally would, but as a neurotypical or normal child would. Number 7, how do cultural factors influence the application of the medical model? Cultural factors influence the application of the medical model by influencing how the individual views health and illness, how they describe their symptoms, how they ask for help, and even how they respond to seeking treatment recommendations. Cultural factors play a big influence in the application of the medical model, both for positive and negative effects.
Thank you. Now we will hear from Elizabeth, who will answer our last two questions.
Okay. How does the medical model impact access to services or treatment for individuals with autism? The medical model views autism as a disorder that can be cured or fixed through medical help and can negatively impact access to treatment and services for individuals with autism by focusing on fixing the individual. That leads to interventions that focus on the neurotypical behavior rather than focusing on addressing the unique needs of the individual with autism. Number 9, what are some key principles of neurodiversity affirming practices in different settings such as education or healthcare? Some neurodiversity affirming practices in education would be creating an individual plan, focusing on the person's strengths versus their deficits. In the healthcare system, neurodiversity affirming practices are the use of the holistic approach in which the whole person, including emotional, physical, social health, are recognized.
Thank you. The next two slides are our reference pages. So here is our first slide and our second slide. And that is the end of our debate. Thank you, everybody.
Thank you.